Hospital from Dehradun, Uttarakhand. He'll have 10 minutes followed by 2 minutes of discussion. Dr. Bhatia, please.
Good morning, everyone. So I would be discussing how desks are equal or equivalent or are not equal or not equivalent, and I'll try to be as minimally biased as possible according to my personal experience. And the past 25 years, we saw the advent of the drug-eluting stents and the advent and the exit of the bioreabsorbable scaffold that might promise to come back. But the journey from second generation DES to BRS was not associated with better mechanical performance, and there was increased chances of thrombosis, especially late and very late. And we have to understand the progress in catheter technology has not occurred in isolation. There has been advances in imaging, FFR, better lesion preparation, and better adjunctive pharmacotherapy that drove most of the results by reducing the bleeding risk or increasing the bleeding risk as per the interpretation might be. So the improvement in generation was not isolated so far as stents were concerned, and the first PTCA that was just done with balloon dilatation, even though that single outcome was great. But nowadays complex PCI is on rise, and we are handling a lot of complex lesions to the tune of 50% with a lot of CTOs. So we have to not just treat acute closure, not just prevent acute closure, we need something that could address the restenosis as well as stent thrombosis. And the different generation of stents that we have, almost all of them are mTOR inhibitors, which so far as sirolimus or everolimus are concerned. And sotarolimus has a more lipophilic nature. So we have actually, since 2007, we have gone to the second generation of stents with various stent designs, and we are focused on different stent properties like flexibility, biocompatibility, reduced thrombogenicity, better visualization under an X-ray, less elastic recoil, better radial strength, less of foreshortening. But the unfortunate part is that if we try to increase the cell size or wall coverage, that might reduce the plaque prolapse, but it might also reduce the side branch access. If we increase the stud thickness, it may improve the radial strength, but it may cause more flow disturbance. If we increase the connector number, it definitely improves the longitudinal strength, but it compromises on flexibility or deliverability. So the basic understanding of open cell or closed cell or a hybrid design is of key, and most commonly now we have all the stent types with open cell design, although of different platforms, and the stent strut design is either modular as in Resolute family, or a slotted tube as in Promus family, or again a slotted tube as in Zymes family. So far as Medtronic is concerned, it has evolved from square struts with a slotted tube to a modular design, and now more recently the Onyx core wire technology that is almost a continuous wire even at the peak. And this single wire design provides a fluid range of motion and excellent flexibility, and the platinum iridium core increases its visual appearance on a X-ray. And it has actually taken away with the better radio opacity, but the strut thickness is not high enough, and we all know that thinner strut, like the thin strut and ultra thin strut stents, they definitely have significant reduction in angiographic and clinical restenosis at follow-up. Definitely with its more conformable and a single wire technology, it is an excellent choice in bifurcation, and it is able to overcome the longitudinal stent deformation that has been designed, and also the side branch access with its excellent rounded strut morphology for the side branch as compared to square strut morphology of the other stent types. It is an excellent choice, especially in bifurcation lesions, and the conformability in various bifurcation anatomies, not just a narrow angle or a wide angle, makes it a choice for a lot of bifurcation lesions. So, and especially as we know the overexpansion capabilities, it is one of the best to be chosen. And the next is the importance of the peak-to-peak design that reduces its compression resistance as compared to a more different offset peak-to-peak design that causes the compression, longitudinal compression of the stent in some other stent types. So as we were discussing, we have different kind of stent designs with peak to valley, mid-strut connector, or peak to peak, and as in element platform, a offset peak to peak morphology. So to summarize just the stent design, we know the Zynes has a multi-link 8 cobalt chromium platform with sinusoidal hoops linked by 3 connectors. As contrast, Synergy has 2 straight connectors, and the proximal hoops are linked by more connectors to limit the longitudinal distortion. So they have also improved as compared to their earlier platforms. And the Resolute Integrity has a continuous sinusoidal strand of wire in a helical form, and Resolute Integrity as compared to the other two, it has elutes Zotarolymus with a durable polymer. And it has been seen, so far as Zynes and Ultimaster are concerned, it has a minimal metal to artery ratio that is beneficial in reducing the long-term outcomes. Similarly, the maximal circular axis diameter for the side branch is also better so far as Zynes and Synergy are concerned as compared to other stent morphologies. And since we know from the recommendations, decay crush is the only technique that has found its way into the recommendations. And this is an excellent paper showing different configurations. It has just mentioned 3 stent types, that is Ultimaster Resolute with peak-to-peak design and Zynes with peak-to-valley design for side branch access in various configurations. So makes these 3 stents an excellent alternative for side branch access, especially if we are contemplating decay crush strategy in our bifurcation patients. The next is radial strength. Definitely it is the Zynes that takes par with the longitudinal strength amongst the best, with stent retention amongst the best, and definitely at osteal lesions, the accuracy of stent position with Zynes with the stent edges always on the balloon marker and are easier to visualize. It's easier to visualize the marker, and it is not a variable distance as compared to other stent types. In contrast, Synergy has a focused stent bending and a wider peak at the peak of the stent tip. And it has been seen that the tip profile is lower and a shorter tip for the Synergy stent as compared to other stents with a better crossing profile. So keeping all these factors in design, we have to think about strut thickness, number of rings, 3-link versus 2-link design, stent flexibility, and try to choose our stent, have a different approach for each patient or a different anatomy in such cases. We have to think about the stent material. We have to definitely think about strut thickness, and now like Orsiro, we have an ultra thin strut stent with 60 microns in the lower diameter stents and 79 microns in the higher diameter stents. We have to understand what is the role of polymer thickness, the drug that it's eluting, the elution kinetics, and the polymer type that we would be discussing in the subsequent slides. In fact, it is the polymer and drug that gave advent to the so-called third generation stents. And in the first generation stent, where the polymer was PIVA, PBMA, or SIBS, the second generation Zynes, we witnessed the fluoropolymer, phosphoryl-choline polymer with Endeavor, and now the era is coming where we have biodegradable polymers or no polymer at all. Although we have to understand how the polymer actually degrades over time, whether with hydrolysis, depolymerization, loss of mass, or bioreabsorption, but definitely we have conceptual theoretical advantages of degradation of polymer, and we have a conventional DES to start with and a BMS at later stage. We might have early endothelialization as documented with various stent types, and a abluminal coating, especially like an abluminal stent, reduces its exposure in systemic circulation, and Synergy stent reduces. So we have to decide which polymer is better. We have trials and data for durable polymer or biodegradable polymer or no polymer. But conventionally, historically, we have seen fluoropolymer has the maximum amount of data. And as discussed earlier in various conferences, we have seen about the role of fluoropassivation, reduced platelet addition with these Zines drug, and it was promised that the reduced inflammation with biodegradable polymer sirolimus eluting stents would have a better result. But unfortunately, so the bioscience trial did not show a significant improvement as compared to durable polymer everolimus eluting stents. So in summary, we have to think about endothelial healing, neointimal development, improvement in endothelial function, inflammation, hydrophilicity, and we have to understand about the biocompatibility of this polymer. And it has been seen that the smaller angle, the contact angle of the polymer with the vessel wall, the smaller the angle, the more hydrophilic it is. And in general, the monocytic adhesion is less, and the endothelial healing, like in Resolute DES small study, it showed a better complete endothelial healing with this smaller angle and more hydrophilicity and more functional endothelial healing. As discussed earlier, abluminous is peculiar in the fact that it has an abluminal coating, and additionally it has an edge coating, so it might address the parameter of edge restenosis and the coating of the balloon just adjacent to the stent. In contrast, if you just talk about the drug elution kinetics, it is among the stents that are available, it is Synergy that has the best drug elution kinetics, and as you can see in the graph, the everolimus mass remaining is minimal at 3 months, and PLGA mass remaining is minimal at 4 months. That makes it one of the choicest stents if we are dealing with the high bleeding risk patients. At the very same point, I would like to put a word of caution that most of the trials that are being studied with short DAPT are also addressing various regimes of DAPT in HBR patients, as discussed by the speaker earlier. And we have to think about it in totality, that we are dealing with aspirin-free strategies. Now let's talk about statistics. Most of the trials that we talked about till 2021 now were non-inferiority trials. There were no superiority trials. Actually, they were got in the market so as to have a compromise between pre-market assessments, and we should not slow our speed of innovation. Here we should discuss and think what the Bionics trial actually showed and what it was like. Surprisingly, it was investigator initiated, it is assessor blinded and patient blinded, but the treating clinicians are not blinded. So how far can we conclude from these trials that were creating noise because of large non-inferiority margins? So much so that the consort statement had to be revised twice for non-inferiority trials.
Tanuj, can you summarize?
Yes, still coming to the conclusion, we have to understand it is actually an interplay of patient lesion procedural stent design, and so far as stent is concerned, metal drug polymer. And we have to be aware that the non-inferiority trials might be subject to bias, but till so far, DES with biodegradable polymer coating has been intended to reduce the inflammatory response, but they have not shown any conclusive improvements in clinical outcomes. The only stent that might be promising, which is it's a recent article published in Circulation 2021 that thinks about the DES characteristics beyond the stent surface itself, focusing on drug degradation and elution kinetics. It is a supreme DES trial that is healing targeted. It targets anti-proliferative drug delivery, absolutely coincidental with the smooth muscle cell proliferation at 4 to 6 weeks after DES. And it is a trial that is being assessed at North America, Europe and Japan, and the 1 year outcome is definitely great, and the thought behind this is super awesome. It has a mechanism of electrografting a small nanometric non-erodible brush of PNBMA. It is a very, very small durable polymer, and it is used with electrografting interdigitation, and the outcomes for 1 year are great except for the stent thrombosis. And so far it is only Zines that has the almost 0% stent thrombosis across the trials. And we definitely need an update. It was quite promising and seductive to have a stent without any polymer in follow-up, and it would have expected to have make a revolutionary change, but it was associated with a 4-fold scaffold thrombosis. And let's see what we have the result in future. But as of now, we are not yet done with the progress of DES. We have to reduce the target lesion revascularization, and in a summary, long-term follow-up is necessary. We have to understand the acute performance of stents as well. We should not be destroying the polymer or the struts while delivering in very difficult lesions. So we need to prepare the lesion well. We should think about ostia, bifurcation and high bleeding risk as while we are taking the choice of stents. And this is a final summary slide that shows about the reduced ultra-thin struts or thin struts as compared to larger struts, and the coating that could be circumferential, abluminal or circumferential again in the bio-reabsorbable scaffolds. And all intention is to reduce two rates in future, that is stent thrombosis and the bleeding score. And what the healing targeted supreme DES has in sure, we will see with the Pioneer 4 trial. The result would be coming in 2024. Thank you.
I'm sorry for the interruption, Mr. Chairman. Totally run out of time.
You have rightly said that the drug-eluting stents, they are not plain stents, they are the stent devices actually, and consist of 3 components: metal, polymer and drug. So if you change any of these components, the property of the stent will change. So any new stent which is coming in the market should be evaluating the stent if they are changing anything.
Yes, sir.
So even the delivery system, sometime it will also change the property of the stent. My question to you is that what is the your say on the Provicol as a drug delivery system?
Yes, sir. Sir, even that is very promising. The Coroflex ISR Neo that is using, even that promises to be reducing, means it's almost similar with the biodegradable polymer in practicality, all practicality.
I'm sorry for the interruption, Mr.
After
Chairman, but we
Bhatia,
run out of time for the
very good
proceedings.
presentation. Just one comment that various companies, they will be giving the expansion limit of these stents. For example, 3.5 can go up to 4.5. It may be necessary when you are doing the left main and LED, but for normal practices, if you go for the highest limits as they claim, then that alters the drug delivery system of the stents.
Yes.
So we should try to avoid that aspect also.
And some stents are associated with fractures if we are going
Yeah,
to
sure,
very-
sure.
That's all the time that we
Tanuj,
have.
just
Any
one last.
Yeah.
So I think, Tanuj, a lot of data in the presentation. So just one thing for the audience, that which is the best out of the all, so that people go with a clear message.
Sir, that's what I didn't want to say.
And if not possible,
That he cannot say.
I'm
if
sorry
not-
for the interruption,
In
Mr.
summary,
Chairman.
every
We'll have to conclude the
stent
proceedings of this
is
session. Totally run out of
non-inferior
time.
to
yeah,
each other.
so if not possible,
Bifurcation, we can prefer resolute. Left main, we can, sir, again, it will get very
Yeah,
bad.
so
I'm sorry for the
basically-
interruption, Mr.
basically-
Chairman. We'll have to
statement.
conclude the
Non-
proceedings of
and
this
data
session.
is maximum
As
with
we are
science.
totally
all
running
are
out of time.
non-inferior. It is how you position and place the stent that is more important.
Yes.
Mr. Chairman, my apologies for
Thank you.
interrupting.
Thank you.
Yeah, we
Thank you
totally
very
run out. Thank you very much, chairpersons, and 10 minutes.